Next up, we're going to change gears a little bit, and we're privileged to have Dr. Eric Jensen from the Division of Clinical Surgical Oncology at the university come talk to us about colorectal liver metastases, bowel first, liver first, or synchronous.
For me, this is a fun change of topic. For you, you might want to sleep for a little while, but I do have one important disclosure, and that is that I, multiple times a year, teach a minimally invasive liver course around the country, and it includes teaching people how to use microwave ablation, surgeons to use microwave ablation, and I am going to mention microwave ablation in my talk, so that's an important disclosure. Essentially, this is what I was asked to talk about today, and that is patients who present with synchronous disease in their liver, what's the best way to manage it? And we were sort of chatting in the break room. I recently gave a talk about just how this management has changed over the last decade. So I came to the University of Minnesota in 2006, and I'm going to talk about things today that are absolutely, completely the opposite of what we were doing when I came. So this is a typical patient that we see, though. If that person, we see mostly rectal cancer. This particular person had a colon cancer. But how do we proceed with patients like this who have a synchronous lesion? Obviously, I've shown the fun part. We took the middle of his liver out. But the decision is really, should you have the colon removed followed by liver resection, or the liver removed followed by the colon resection, or combined surgeries? And that's kind of the charge of the day to talk about. Each one of these has lots of data behind it, but none of it is really good data. None of it's really randomized data. It's just observational and retrospective data. And there's arguments for all of them. And the biggest argument when I was in my training for colon and rectum first was that it treats the source of the disease first. So in my training, we would never operate on a liver if the person still had their primary tumor in. We just wouldn't do it. So the people that advocate for colon or rectum first are because it treats the source of disease first. It potentially, I wouldn't say that it prevents obstructive symptoms. I think that's kind of been debunked. There used to be a lot of fear that somebody would become obstructed while they're getting treated. I think everyone in this room especially knows that that is a rare event. But some people do present with obstructive symptoms or near obstruction where you may want to take care of the colon first or the rectum first. Also, some people believe it allows a test of time for systemic disease to progress if they have particularly aggressive disease before you go through sort of more radical surgeries. The problem is that a few things can happen. If you give them treatment up front, people can have disappearing liver lesions. So if they get their colon treated along with chemotherapy. I should also say, by the way, at our institution anyway, anyone with systemic disease or synchronous tumors, they typically going to get treated up front. So that's sort of, I won't say that anymore, but they all get chemotherapy at least up front typically. So people can have disappearing liver lesions if you delay their liver surgery. In some cases, they can have progression of metastatic disease. And probably the only one that I actually agree with is that it can be a major issue to give people too much upfront chemotherapy because it does cause chemotoxicity to the liver. So that's probably the only one I would agree with on that. For patients that have liver first, people argue that it's a good idea because you avoid the chemotoxicity to the liver. You avoid disappearing liver lesions because you're treating them before they've had a lot of upfront treatment. And it treats the most important predictor of survival first. So the thing that's going to kill these people typically is their metastatic disease, so you take care of that first. The problem is that while you're doing liver surgery and delaying their primary surgery, again, I think the risk of this is very tiny, frankly, but there is a risk that they develop complications from their primary tumor, and it can delay the remainder of their systemic treatment, particularly if they have complications or other things happen after their liver surgery. I think those are minor issues, frankly. And synchronous resection, obviously it allows you to treat all the disease at once. I think patients prefer synchronous resections. I like doing synchronous resections, frankly, because I think it's nice for the patients. But it can be technically more difficult or risk prohibitive depending on the patient and depending on the combination of what they need done. Low rectal resections combined with major hepatectomies, as I'll show in a minute, do have some issues. So the important thing about this is there's nothing to do with survival. All these choices really have nothing to do with survival. It's all about patient selection, trying to figure out what's best for the patient, limiting the number of surgeries, the safest surgeries, things like that. So this is the only slide I'm going to have about colon first resections because I think everybody is familiar with this data. This goes back a long way. Nobody's really publishing this anymore in the last 5 years because everybody knows it's true, or I should say has accepted that it's true. But anyway, people that have staged resection, these are all colon first. there's a couple of these that include some rectal cancers. But basically, it's important, everybody in this room knows, 5-year survival for somebody that has a liver resection after they've had a colon resection for a primary colon or rectal cancer, their survival, 5-year survival is 25 to 60%. Okay? 60% on the high end is pretty good. We're not going to get into that details of those patient selection, but nowadays most of our patients fall into the 40-50% range. That's basically the same as saying median survival is up to about 75 months almost as a median survival. So clearly doing these surgeries works. Deciding on the timing is a different thing. We looked at, our group, we published national database data about looking at the outcomes for patients that have combined colon and liver resections, and we kind of separated them out. CCLR just stands for combined colon and liver without a hepatic lobectomy. This is colon resection. This is a liver resection without a lobectomy, and then lobectomy only. And CCLR with lobectomy is sort of a colon resection with a major hepatectomy or lobectomy. And this is kind of a busy slide, so I will just basically summarize by saying there was not a difference in mortality. There is a little bit longer hospital stay if you combine major colon surgeries with major hepatectomies, but the risk of morbidity was essentially completely dictated by patient selection. So the only things that turned out to matter on multivariate analysis were essentially a patient's age. Clearly people that were older had a higher risk of morbidity with these combined, this was for combined surgeries, and their Elix-Hauser score, which is basically a composite fitness score based on multiple comorbidities. And clearly patients, as you have a rising Elix-Hauser score, so things like heart disease and diabetes and all that kind of stuff, clearly they do have a higher risk of morbidity. So I liked Mark saying about patient selection being the king or the queen, I guess, along with biology. But so patient selection is really the primary thing. The same year that we published that, another group led by Tim Pollack published an international retrospective review of their data. They looked at 1,000 patients. Again, this is actually 5 years ago, but they were looking at data from, obviously years before that. But what is kind of striking, they looked at over 1,000 patients. Only 28 of those patients had liver first. So it tells you how things are changing, because I'm going to show you how we're doing things very differently now. But basically, they looked at a lot of colon first, a moderate number of synchronous, and then a very small number of liver first. And basically, there was absolutely no difference in morbidity, mortality, or survival. So it really has to do entirely about patient selection, because clearly it's completely biased who you decide to do synchronous. They're going to be the most fit, the most straightforward surgeries. Patients that get colon first are a lot of times a little bit more frail or things like that. So patient selection is what affects this. But if you select patients well, there's really no difference in how you treat them in these measures anyway. Interestingly, only 50% of patients, and these are patients who all have metastatic disease, but it included a lot of international, it was a lot of heavily European groups. Only 50% got chemo of any kind at all, and only 11% got chemo before surgery and after, which is how we manage things here. But these are just the survival curves to show they're the same. So my argument for synchronous resections is generally that no patient has ever wanted 2 surgeries when they could have 1, and they're not minor surgeries. So I don't want to offend anyone in the room, but like an ostomy takedown, maybe we would say is minor. Is that fair? We'd call that minor relative to an LAR or an APR or a hepatectomy. So generally, patients do prefer if we can do things all at once. What's happened over the last 10 years is essentially that we, instead of doing the colon first or synchronous even, now we're starting to do much more liver first. And part of it has to do with what Wolf was talking about and the fact that people are now getting a lot more upfront therapy. And the patient population that we see at the U is definitely skewed towards rectal cancers, the patients that I see anyway. And so we're dealing with people who are getting a lot more upfront therapy. And that's one of the main reasons that we do have to consider liver first therapies, because otherwise the liver suffers from the chemotherapy that you're giving. And this is a millennial. And this is a terrible story, because Mark just mentioned this exact thing. This is a 35-year-old guy. The worst part about this is he had a brother who died of metastatic rectal cancer in his 30s, and he actually went to his doctor with rectal bleeding and told them that, and he was still told it was probably a hemorrhoid. Unfortunately, it was about 6 months later that he showed up with more bleeding and sort of almost obstructive type symptoms. But anyway, I just showed his scout film, which we almost never look at, but his is pretty impressive. So he has a big rectal tumor, and then he has a met in the left side of his liver and several in the right. This type of patient is a person who's going to get a lot of therapy, systemic therapy. And if there's any hope of surgically resecting these patients, this is just the MR to show the extent of that disease. I put big fat arrows, so anyone who's not used to looking at the liver, there's a lot. I didn't put it for this crowd. That wasn't meant to be a slight on anyone here, but I like the big arrows. It makes it easy for me too. So anyway, but you can see he's got extensive disease. And actually, in my residency and even in my fellowship, which is, 12, 13 years ago, 13 to 15 years ago, this is a patient we probably wouldn't have operated on, actually. And I think things have changed. I'm going to show a little bit about that. But a lot of times these patients would be on systemic therapy, and that would be the end of their story. This particular patient, and I show him because we did operate on him. And actually, he was a liver-first approach where basically we took out this lesion, and then we used microwave ablation to treat the lesions on the right side. And that's a new technology that's also allowed us, again, I fully disclose that I do get paid to teach people how to do that. But that's a new technology. Ablation technologies are something that has allowed us now to treat people that we never would have treated before with more extensive disease, and we preserve more of their liver, so the toxicity that they get from their ongoing chemotherapy, which is something no one ever talks about, but it limits how you can treat people. When they're on long-term systemic therapy, the amount of liver in their body is actually very important for how well you can treat them. So this person we did resect, and we treated those lesions, and he got subsequent therapy. And this guy was actually a very unfortunate case because he has recurred in his liver. He's got a particularly aggressive disease, but he's living his life with his rectum currently, which in past years we may not have done. He'd be having a worse quality of life potentially because he would have gotten a very low rectal resection with radiation and all other stuff we used to do. So at the moment, he's still being treated on chemo. His liver at the moment is clear because he got retreated. So we're still waiting to see what happens with his rectum, whether that'll ever come out. So liver first, just as a first byline, liver first is really good for patients where the liver is the most complicated portion, or in patients that you know are going to need long-term systemic therapy. And by long-term, it's a talk for another day, but systemic therapy generally is either Folfox or FOLFIRINOX, or FOLFIRI, excuse me. Irinotecan causes steatosis of the liver, it causes steatohepatitis of the liver, and it can do so even in as little as 3 cycles. So in general, and oxaliplatin causes what's called sinusoidal obstruction syndrome. So for patients that need liver resections, those two things really increase the morbidity and even the mortality of liver surgery. And that has been well studied. If you have patients that are getting 3 months or less of chemo, it's probably okay. But once you get beyond 3 months, and certainly if you're giving somebody 6 months of chemotherapy, then it really limits what you can do to their liver without increasing the risk of mortality. So we, at the U, we've started doing basically sort of short course chemo up front. So we usually give people 6 cycles or 3 months basically if we're doing that. We'll give them 3 months of therapy, rescan, and make a decision about their liver surgery, and then continue on with whatever else needs to be done. So one of the other things that we have a problem with now, or no answer to, I guess, is what if they have a complete response of their primary tumor after they've gotten their neoadjuvant chemoradiation? And I'm not going to get into this, obviously, because it was discussed, but I will point out one new publication in Lancet just a few months ago. This is for the Worldwide Watch and Wait database. You could probably argue about the validity of some of these huge database registries, but this one I thought was pretty interesting. They've got over 1,000 patients registered now. Mark already talked about the data, so I won't go into detail about that, but I would just say that it's probably, I would certainly agree, even though it's not my specialty, that it's probably an appropriate thing, that there are patients you can select where it's appropriate to watch and wait their primary tumor because they've had a complete response. And for those patients who do recur after salvage, the 5-year survival in this group so far anyway is 75%, which is about what you expect for other rectal cancer primaries. And I think Mark mentioned also that it's a very low risk of actually having metastases develop in patients that you've watched and waited. So I would say my bias would be that it is reasonable to do. The issue is now we got patients that we're treating their liver first, and then we have a patient who may have a complete pathologic response in their primary tumor. I don't know the right answer to this, but this is what's happening. We have a few patients now where this is what's happened. We've treated their liver up front. we've gotten rid of their metastatic disease, they've gotten the remainder of their treatment for their primary tumor, and it's gone. So we have a small but growing, slowly growing number of patients where they've got a scan like that first guy that I showed, where they've got multiple tumors through their liver, but we've been able to get rid of them. I'm going to show another one in a second. And then the primary's gone, so we're waiting. I don't know if it's right or wrong, but I think it's right. That's why we keep doing it. Now, one of the issues, as I mentioned, is we're able to do more to the liver now than we used to. And so part of the reason we have to be a little bit careful, and part of the reason why we're doing liver surgery first, is because we want to do it before they've had too much chemotherapy. And again, as you're treating rectal cancers with more and more upfront therapy, it becomes important to do it, especially some of the things we're treating now. So this one is kind of mixing things because this is a lady that we did a synchronous resection. But this is a 48-year-old lady. She had rectal bleeding. She had a T3 cancer. And I just want to point out, this is mainly to show this group that we probably can treat more in the liver than a lot of people think we can. This is her scan when she presented. And this one, I didn't put arrows, obviously, but there's one here, there's one here, there's one here, here, here. There's one there, and there, and there. That's just a fissure, but there's one there. There's one there, there's one there, there's one there. There's there, there. So there's not a segment in this lady's liver that doesn't have cancer in it. Okay? So this is another one that we never would have treated 10 years ago. She would have gotten chemotherapy, and that would be sort of her destination therapy, if you will, or palliative therapy. But after she got just basically a few months of chemotherapy up front, which is kind of what we've standardized doing, I use MRI heavily, especially if we're treating multifocal disease, because the last thing you want to do is go and treat 4 lesions or 5 lesions, and then you find out there were actually 8 lesions, but you didn't see them on a mediocre CT scan. So we use MR a lot. But on MR, after she got treated, here's one. She's got a couple on the surface up here, one over here, one over there. So she had a really good response. You can see there's actually still some over here too. So she had a very good response. It makes it easy to select patients. I also like the saying about the gambling. It's easy to gamble when you can predict who's going to win. So anyway, people that have a good response like that, we do treat them very aggressively. This particular person, we resected 2 of her lesions. We ablated 7. She had a combined low anterior resection. She went home on day 3. She got the remainder of her adjuvant therapy. This one's we've been following her a little bit longer. 18 months later, she had a single recurrence in her liver. We took her back to the operating room. We did a laparoscopic partial hepatectomy. She still has like 90% of her liver left in her body, and she's disease-free, and now we're a little over 2 years later. So it's one person, but it sort of shows the trend towards being able to treat more and more disease in the liver. This particular one we were able to do laparoscopically, or minimally invasively anyway. I think just to final state about that, there is more and more data. A lot of people really question whether we should be using sort of ablative techniques for metastatic disease. There's a lot of people who don't believe in it, or they say the risk of recurrence is very high, or things like that. And actually, all the data so far is observational, but this is a phase 2 trial. Sorry, I just realized this is red, so I'll speed through this. Very briefly on treating patients like that, this was a phase 2 randomized trial, 119 patients done in Europe. These are patients that had up to 10 lesions in their liver who got randomized to either chemotherapy alone or chemotherapy plus ablation of their liver lesions. This shows the risk of intrahepatic recurrence. The systemic chemotherapy is up here. The treated patients with ablation are down here, so a lower risk of recurrence. This is the systemic recurrence. Okay, so systemic recurrences were exactly the same, even if you had up to 10 lesions in your liver. So you're not wasting your treatment on people. And this is the overall, basically, survival. This is patients with systemic treatment, and this is a long time, 12 years. And the dotted line is patients who got ablation as well, up to 10 lesions. So clearly, these curves are remaining divergent long after the treatment. So the median survival doesn't look like it changed a whole lot, but the overall survival is significantly different for patients that got liver-directed therapies in addition to their systemic chemotherapy. So just to summarize, since I'm running over time, thank you, Mark, for being short. Not height-wise, but time-wise. So in summary, the colon-first approach, it's nice when we're all friends, right? The colon-first approach, we've actually, I don't remember last time I had a person that was colon first who had synchronous disease at the time of their presentation. It's totally reversed from how we used to do it. But the patients that we do occasionally do it, it's usually because they're near obstructed or they're having bleeding or some reason that the primary has to come out without upfront therapy. But otherwise, all of our patients are getting chemotherapy or other things first. Sometimes in a frail person, if you're not sure they'll tolerate combined, sometimes it's good to do one or the other first. That would be another reason. But again, it's becoming much less common. Synchronous is nice whenever we can do it. They're best treated, it's really nice when you can do it. The problem is now we have a little bit divergent issues because the liver, you don't want to give too much chemo. And for rectal cancers especially, now we're giving them all kinds of treatment before you do anything. So it's becoming less and less common that we're able to do synchronous resections. The liver first, to my surprise in some ways, has become what we're doing most of now, which is totally the opposite of what I would have said 10 years ago. For all the reasons I mentioned, mainly chemotoxicity and the complexity of rectal cancer management, we're starting to treat the liver first to allow us to do those multiple resection, ablation kind of things. We've treated one person with as many as 20 lesions in their liver. So we can do a lot of things as long as their liver is healthy. And I would also advertise to this group and others that aggressive liver-directed therapy, as long as you can treat all the lesions, makes no sense to treat some and leave the others, but as long as you can treat everything you can measure, it does seem to have a survival benefit. Thanks.